Well, hi, everybody. My name is Garrett Schmidt. I am the CEO and managing editor of VBC Exhibit Hall, and I'd like to welcome you all to today's live webinar hosted by Connective Health. This is the first one we've done with them, so very excited to be working with them now, and I'm really excited about the topic today, and I know a lot of you are too. We've got a big audience, and it is called the Clinical Leaders Playbook for HCC v28 and RADV. And a few items of note before we get started today. Everyone has joined today in this is a traditional webinar format. Everyone has joined today in listen only mode. So you don't need to worry about turning off your camera or your microphone or anything like that. We can't see you or hear you. However, we do want to hear from you, and we're going to have a time for some Q&A towards the end of our presentation today, or our discussion rather. And if you have a question for any of our speakers that arises at any point, you can go ahead and use your attendee module. There's a place for questions specifically there. Drop your question in. We're going to get to as many as we can. We got a lot to go over today and discuss, but we're going to get to as many as we can. If we don't get to yours, though, for some reason, don't worry. Someone will make sure to reach out via email to make sure that you get your question answered. Finally, the session today is being recorded, so what's going to happen is when we conclude, maybe about an hour or so afterwards, you'll receive an email, and that email will have a link to the recording as well as to the slides. We don't have a lot of slides today. Most of this is going to be just kind of a fireside chat type of discussion, but there will be some contact information and that kind of thing in those slides. So if you want to download those, they will be available to you. Without further ado, wanted to briefly introduce our speakers, and then I'll turn it over to them. Today with us we have Dr. Scott Williams, and he is the Associate Medical Director for ilumed. We also have Dr. Jim Taylor, and he is former chair of Colorado Kaiser Permanente Medical Group and national director for Iora Health, and is a consultant to the Connective Health team. So glad to have him. And then moderating our discussion today is Mr. Shane Callahan, and he is the VP of Sales with Connective Health. So welcome, gentlemen.
Thank you, Garrett. Thank you so much. I really appreciate the introduction. Appreciate your partnership for getting us set up today. And also thank you to the audience for tuning in and carving out some time to spend with us. As Garrett mentioned, our topics today are going to revolve around how clinical leaders are helping providers to navigate the shift to the V28 model and the increased rigor of RADV audits. So really excited about the speakers that have joined us, and I will be moderating that discussion as VP of Sales for value-based care here at Connective Health. So also we'll mention, Connective Health, we specialize in helping value-based care organizations succeed with access to actionable external insights. So specifically those medical records that exist outside of claims data and the native EHR, for example. And so with access to external insights, providers can better engage with their patients and optimize risk adjustment, quality performance, and utilization management. So today in particular, we're of course focused on risk adjustment. And before we dive in, I think it makes sense to pass it back over to our speakers for some more robust introductions. So Dr. Williams, I'll start with you if you don't mind.
Thank you. I'm very excited to be here today. So I'm Scott Williams. I'm a family physician. I live up in Maine. And then as mentioned on here, I am an associate medical director with ilumed, which is a ACO REACH program. So based out of Florida, but we work with partner groups throughout the country. And one of my, primary focuses with the ilumed group is on, making sure we get our risk adjustment, or as we call it, burden of illness program accurate. I also, before joining ilumed, held similar roles at Maine Health, and so working with Maine Health and Maine Health ACO on their Medicare Advantage programs, including MSSP as well. So thank you.
Awesome. Thank you so much, Dr. Williams. And Dr. Taylor, over to you, please.
Sure. I'm Dr. Jim Taylor. I'm a family practitioner of 35 plus years. I've been saying that for several years. I'm also a certified coder for about 15 years. I started in a small farm town in Ohio, 8 years of private practice delivering babies, first assisting on surgeries, all that crazy small town stuff that people actually still do, bless their hearts. I don't. Moved to Denver and joined Kaiser for 1 year. That turned into 20 years. And the last 10, I primarily was doing Medicare Advantage, or back then it was Medicare Plus Choice. So I started to help get Kaiser ready in 2003 and was there during the ramp up 2004 to 7. And then I've been doing it ever since 2008, full time. We had 100,000 Medicare Advantage patients. After Kaiser, I went to help start up a company called Iora Health, or start up their Medicare Advantage line of business. And they were eventually bought out through a series of companies by Amazon. So when you go to Amazon and say you want healthcare, if you're over 65, it will be one of the Iora clinics that we established. After Iora, I was for 1 year Humana's National Director of Medicare Advantage. So I'm very familiar with risk and all the nuances of both the clinical side and the back end side. And my mantra and my passion is to make the right thing to do, the easy thing to do, to keep the administrative tasks off the physicians' backs.
Fantastic. Well, thank you, Dr. Williams and Dr. Taylor, for those introductions. I think it's clear we have a lot of experience in this conversation today, and some really awesome and topics to dive into here. So I'll just try to ground us some more here in setting the stage for why we're here today. And really, again, it goes back to considering the just rapidly evolving state of value-based care. Again, that transition to the V28 model and some of the increased rigor of RADV audits emerging as just key challenges for ACOs and for providers that are continuing to be worked through. And it's truly turned into an inflection point for the whole industry. So as we think about increased coding complexity, while it may be clinically useful, it's also projected to decrease overall risk scores as much as 3 to 5%, and also increase audit frequency, which opens up providers to more risk. So ultimately, really begging the question here: how can ACOs and providers evolve alongside these changes, and how can they strive to deliver the highest quality of care while also protecting reimbursement? So that brings us to the themes that we're going to spend some time on today with Dr. Williams and Dr. Taylor. And those are the 4 on our screen here right now, which is, starting with how do we earn a provider's attention and enable accurate condition capture without adding to their workload. Also, how external medical records sourced beyond claims are a strategic imperative. How to make chronic condition insights more actionable for providers. And also what the future holds for risk adjustment and chronic condition management as a whole. So with that said, I think it might be helpful to shift gears here into a poll question. We're going to have a few different poll questions today. So Garrett, if you could help us get started with number 1, that'd be great.
All right. Yes, we're going to have a few polls today, so this will be somewhat interactive. If you want to play along at home, this is, by the way, anonymous. So this is just more for information's sake, and thought it would be interesting for you guys to see sort of where you stack among your colleagues. The question is this: what is your organization's primary area of concern related to HCC coding and RADV audits? And we're going to give folks a moment to answer here.
Perfect. I'm seeing some answers trickle in here, which is great to see.
Yeah. So, and again, for those of you who are just joining us, we're going to have a couple of these polls throughout, so keep you on your toes. And then we'll show the results here momentarily. And again, this is anonymous, but it's just kind of so you can see where you stack among your colleagues and what's going on in the space.
Definitely.
I think most of the answers have come in at this point. We'll give it maybe 10 more seconds for folks to respond, and then we'll close it down.
Sounds good. Should help us understand where we can take our conversation today as well.
Yeah, exactly. All right, folks, I'm going to shut it down in 5 long seconds here. 4, 3, 2, and 1. And then we'll show you the results. All right. Are you guys, Shane, are you able to see the results on your screen? And if so, could you read out the percentages for those who are calling in?
Yes, absolutely. So starting with our highest responded, ensuring accurate and complete clinical documentation. So we saw 63% of the group here today marking that as their primary area of concern, which is definitely not a huge surprise there. Also, provider engagement and reducing administrative burden, 17% respondents, 5% with integrating and making sense of data across multiple sources, and 15% with the financial impact of potential reimbursement changes as well. So really helpful to understand where, for those of you who are tuning in, what's really top of mind for you here. And for Dr. Williams, Dr. Taylor, I think it'll be really helpful to hear if anything in particular surprises you about some of these responses. But maybe just to start with a question, Dr. Taylor, for you, what is the single biggest operational or clinical challenge at this time related to risk adjustment strategies that healthcare providers are still underestimating?
Yeah, I would say the biggest clinical, the biggest clinical barrier is the time to do it all. So making the right thing to do, the easy thing to do by turning on certain functions in your EMR, just trying to make it easiest for the doctor to accurately represent their patient's care. The other aspect would be working with the physicians. Change feels better when it's done with you rather than to you. So involving clinicians in that will help overcome any of the barriers. But really, the biggest barriers. This is something new for some. Used to be everyone. It's something new where before we just checked any old diagnosis, we'll get it through the audit systems, and now the specificity and accurately representing the condition is more of the focus. So just really helping navigate through those changes is a barrier. Administratively, just getting the clunky process. There's got to be integration with the EMR and other things. Once again, because the docs are busy and we didn't go to medical school for all of this, as I've heard over and over and over. So we just have to help them out.
Yeah, no, that makes sense. And Dr. Williams, would love to hear from you here as well.
Yeah, Jim, some of the things that you brought up there, it really makes me think about when I'm going out and talking with other physicians, whether they're partner groups or just colleagues in general, about this transition into the value-based care space, because it really is like a transition a lot, and people are at very different life cycles with it. And with the different life cycles comes different levels of understanding. And, in medical school and in residency, we learned a little bit sort of about the business of medicine. And it was, I'd say, functionally like kind of what we needed to know. And that was, like you said, you got it in the fee-for-service world, you're asked, how much did you do? You're not asked like what exactly you did. It's more how much. How many diagnoses? Did you order labs? Did you look at records? Did you consult a specialist? And so people are really familiar with thinking through how much, but they're not so familiar with thinking through what. What did you manage? What was the complexity? What was that, as we like to call it, the burden of illness of that patient that you were caring for and you were thinking through? What's that complexity? And it's a different mindset, and systems aren't really set up for it. They're set up to be successful in fee-for-service. They're successful to get a diagnosis in efficiently. They're not set up to get the most accurate or specific diagnosis in efficiently necessarily. Your clinic schedules, they're often set up around how many people can you get through as quickly and efficiently as possible, but they don't necessarily step back and think about the complexity that you're asked to think through in the risk adjustment and value-based world. And so it's just like you're saying, it's like very much a structural thing that you have to go through, and change is hard, challenging, and unfamiliar. And I really like what you said there of bringing the physician in so that they can be, part of the change making process and not being necessarily just told exactly what they need to do. And really, I think part of what you're saying there is they need to understand the why under it as well, so that they can really be informed in making those decisions going forward.
at Kaiser, initially, there's 5 or 6 regions in Kaiser, and in Colorado, we were pretty successful in getting physicians to navigate through that change for some of the reasons you did. And when people would ask me, well, how'd you do it? I said, well, we didn't teach coding, we changed a culture. So more change management techniques are needed, not just by clinician to clinician, but medical group to clinician. And, and so that's actually had them send me to an accelerated implementation methodology course, because that was more valuable than a coding course when we first started out.
As you're talking about, you're not really, you're trying to bring in not so much, you want to teach coding, you want to like keep it grounded in like clinical medicine. And one of the things that I like to talk about with other physicians is as they're trying to understand the why and the how of making this change from the fee-for-service world into the risk adjustment and value-based care world. You brought to mind one of my examples that I think really resonates well with people because it's so grounded in clinical medicine. I like to put up 2 patients, and they're both 72 years old. They're both females. They've both been seeing you in your clinic for a long time. And so you know them well. One of them has 3 chronic conditions: high blood pressure, high cholesterol, and knee arthritis. Another also has 3 conditions: diabetes, chronic kidney disease, and knee arthritis. And why I like thinking about this and using it as an example, and it really kind of keeping it integrated in the clinical medicine, in the fee-for-service world, both those patients, they're coming in, they've got 3 issues, and one of them is probably uncontrolled, but they're all treated with medicines. They're both going to be 99214s. But if you ask any clinician, who are you spending more time thinking about before the visit, during the visit, after the visit? Which one's going to be much more complex for you to think through? They're all going to say the second patient, the one with the diabetes and the CKD. Because if they come in, they both want their knee pain treated, your whole tool belt is open to you for the first patient. You can do a steroid injection. Of course, PT is on the table always. And you can even maybe say, try a short cord NSAIDs. The second patient, way more complicated. Is that injection going to send their blood sugars out of control? Is that injection, is that short course of NSAIDs going to be risky for their chronic kidney disease? You have, far fewer options available to you there. And so when you kind of step back and you say, really the ask here is to get as granular and specific in naming just how complex your patients are. And then you will be kind of rewarded the resources and hopefully time to think through and properly manage them. It makes that, that visit for the for the knee arthritis, it does make sense why you do need to be saying, yep, this patient also has CKD, they also have diabetes. You need to be, having access to and bringing forward the full complexity of care you're thinking through and managing that day. I think when I put it in that terms for the physicians, that really just like put down the full scope of what you're thinking about, it really seems to resonate with them a lot more. And so it doesn't feel like this exercise in coding, doesn't feel like this exercise in chasing down finances. It feels like an exercise in like really going through and displaying how complex the care you're providing is.
That's a really helpful outline and framework there, Dr. Williams. I appreciate you putting it in that way, and I think it really nods to the understanding of the needs of physicians and also empowering them with something that is actionable as well. And so that actually brings me to another, I think, related area of the conversation today, which is provider trust and actionability. And in particular, how you can earn a provider's attention to enable success in these areas. And so this actually is our second poll question of the day. If Garrett, if you don't mind helping me pull that one up.
All right.
Perfect. And I can read out the question here, which is essentially, what is the biggest barrier that you have today in getting your providers to consistently and accurately capture chronic conditions? Could be time and competing priorities during patient encounters, training on specific coding and documentation requirements, and understanding how their work impacts reimbursement and patient care. So we'll give the audience another minute here just to log some responses and see where that takes us.
Yeah, very good. And so again, same as before, you should see this up on your screen. And again, if anyone's joining us a little later here, these are anonymous. This is just kind of for fun and to see where you kind of stack among your colleagues here. And yeah, we're going to give this maybe, I don't know, about 10, 15 more seconds, and then we'll close it down and show you the results.
Sounds good. Thanks, Garrett.
Okay, I think most of the results have come in. So I'm going to go ahead and close it down here in another 5, 4, 3, 2, and 1. There's always one that comes in right at the end there. All right. Shane, are you able to see the results here?
I sure can. And I can read those out for the audience here. So coming in at 52%, so definitely the most popular answer here is time and competing priorities during patient encounters, which is a theme we've most definitely already heard a bit of from Dr. Taylor and Dr. Williams. And then also 23% of the audience had training on specific coding and documentation requirements, and 25% of the audience had understanding how their work impacts reimbursement and patient care. So definitely a bit of a split across the board for these three areas. And appreciate the audience giving us some sense of where they are here in this journey. And so, Dr. Williams, I was going to ask you the question about any real world examples that come to mind. I think you already shared a little bit of that in your previous comments there, but I'm curious as you reflect on some of these answers, if anything else comes to mind in particular when you reflect on the work you're doing at ilumed in this respect.
Yeah, the time and competing priorities really resonates true. I mean, I don't think there's a clinician out there who feels like they've had adequate time and resources to get through everything that they think is meaningful for their patient. But in response to your more direct question, and I'll try and connect them together, I do think back to a real clear patient example where I think the risk adjustment and value-based arrangement really helps you prioritize the time and how you're going to kind of address a patient. So it's actually my introduction to this work was really being part of a team and leading the team that did manual chart reviews. And so we would go through and we would look at the patient's chart and try and see what's been diagnosed about them and known about them, what's in their problem list, what's gone out on past claims, and then kind of what's the objective evidence in the chart, notes, imaging, labs, anything that we could really think would meaningfully guide us one way or the other on being able to name the patient's burden of illness. And I was new to this and I kind of had a rough understanding that, HCC diagnoses, they're complex diagnoses, they're heavy hitters, but I didn't really fully understand the importance of getting real granular and naming them until I did my very first chart review on my own. And so the goal of this chart review was to surface information for a colleague to consider. And it was both things that I thought maybe the patient has that no one's named yet, and often when you're not naming it, you're not managing it. And also to say things that, I see this has been named, but I'm not sure that's quite where the medical evidence is pointing. So really, truly trying to just get to their kind of burden of illness no more. This patient was a patient who came in, she was probably 75 or 80 years old, and she'd had a long time PCP, saw this PCP once a year, and you could almost see the notes were just a copy forward every year. And I'm not saying that in a bad way. I'm just saying she was very stable. She had asthma, she had high blood pressure, and that was about it. And she would come in, she'd check in on those. When we really dug into the chart, though, I started looking at her lab tests, And I noticed that over the past 5-6 years, she'd slowly had a down trickle in her EGFR. She was actually now kind of on the borderline of CKD 3A and 3B. So not even just crossing over into 3A, but like it seemed like she truly had CKD at this point. I also went back and I looked, okay, she has asthma. Let's see if she's ever had any testing done around this. And I saw that there was spirometry in there. And it was actually COPD. The spirometry didn't support asthma, it actually supported COPD. And looking back, she had a history that would go along with that. And then the final kind of thing that I noticed was just slow, kind of insidious weight loss over time. And she was now kind of getting into being borderline underweight. And all of these things were just very slow trickles over time. And easy, if you're seeing someone once a year, they come in and they say, I'm doing fine. It's easy to explain them away. But taking a kind of step back and thinking about like, what's actually going on here? This is someone who's slowly in decline. They've now actually truly got objective evidence of CKD. They have progressive weight loss that on its surface didn't really have any clear answer for it. But when you look, she has COPD, not asthma. COPD does tend to be it can be an insidious, slowly progressive condition itself. And each condition on its own didn't seem that big, but when I sort of took the whole picture together and I said, you know what, I think this is actually really what this patient's true burden of illness is, and got that in front of the provider, I noticed that their note that year, although the patient came in and said, yeah, I'm still doing fine, doing great, it actually caused the provider to pause and say, you know what, we're going to have a slightly different conversation this year. And they actually went through the COPD, the CKD, and the slow weight loss, and they said, hey, we're trending in the wrong direction here. You're well now, but let's start planning for like, what is the next 6 months? What is the next year? What does the next 3 to 5 years look like? And kind of what are your goals of care? I haven't had the opportunity to follow up on this patient since that time, but like, taking it back and really being intentional and thoughtful about the risk adjustment process and pulling that information together from like the entirety of the medical chart, it was really impactful. And, it allowed for a proactive, thoughtful conversation at a time when it could have been easy to just be like, this is one of my uncomplicated patients. I'm going to get through this quickly and move on to the next patient, and maybe more like in my face, acute today.
Yeah, that's a really helpful patient story, Dr. Williams. I think it really brings to life some of the important frameworks of how you can tie a risk adjustment strategy into not just identifying the problem, but also translating it into an improvement in care there as well. And Dr. Taylor, I'd love to hear some more from you around your perspectives around some of what Dr. Williams has shared, or anything else around provider actionability.
Yeah, so the time burden, in the poll, the burden, the administrative burden, the time, all of that is important. What I would tell our physicians is, give me 5 seconds now, or give me 5 minutes later. So there are some tricks in the electronic medical record, and when you write your prescriptions, if you just say hydrochlorothiazide for hypertension, and in the SIG, it gets propagated every single time that you point to those medications or bring them into your note. So you've just given the RADV auditors evidence that the patient's being treated for this condition, and you just have to add, well, they're stable on meds. Then they go to the med section that you've imported into the note, and it says duloxetine for major depression. And then you specify how much in the note. So 5 seconds now, you set that up once, and then you're cruising the rest of the time, because the EMR is your friend, not your foe. The other thing that I teach is the magic words. So you don't have to write a book. Physicians, clinicians, we treat hepatitis C. We don't treat acute hepatitis C because most of the time people don't even know they have it. But if it turns into chronic hepatitis C, it can cause cancer and other problems in their liver. So when we say hepatitis C, we mean chronic. It's kind of a duh kind of a thing. But if you don't say that in the medical record, chronic hepatitis C, which takes less than 5 seconds to just click on the right button, then you're going to get a query. And then you have to take the 5 minutes and answer the query and put the evidence and all that. So there's a lot of 5 seconds now, 5 seconds later strategies, including just teaching the magic words. They've been getting excellent clinical care for their hepatitis C all along. We just didn't say chronic, which to us is a no-brainer kind of a thing. The other thing is too many organizations that I've consulted with, my life is simple. There's ideal, okay, and wrong. And so too many times they try to bring docs from wrong up to ideal. And that's the fastest way to slow your process. Is they don't want to be ideal. They just want to be okay. So getting them to do the right thing, the okay thing. Yeah, if you did it this way, you would pass your coding certification test, but you don't need to. Just get enough information in the chart to make it okay. If you take those strategies, the biggest thing you're going to gain from that is trust. And that's the secret sauce. If they think you're out trying to do a money grab, and they're helping you with stock value of your company, they're not going to be interested. Well, unless they own stock. I'm kidding. So helping them, assisting them, saving them. It doesn't necessarily mean more money for them. Many times it doesn't mean more money for them, but what I tell them is, I'm going to give you something more valuable, and that's time. So investing in saving time with drop-down lists and the magic words, and 5 seconds an hour, 5 minutes later, you're going to gain somebody who's more dedicated to the process than somebody who's just following the stinking rules.
That's a excellent perspective there, Dr. Taylor. I appreciate you putting it in those terms and grounding us in the importance of, culturally and process-wise, why the 5 seconds earlier on is very valuable when you think about the 5 or more minutes it could take in a later stage. And I think that's also another good segue into our next section of the conversation today, which is going to be on the importance of thinking about external insights, those insights that are sourced beyond just the claims data that providers may be using for their risk adjustment strategy. So, this is a big part of what Connective Health does for providers. And, the way we see it is the tools to be successful in value-based care have evolved quite a bit. And it involves, on the one hand, gathering a breadth and depth of data across a variety of sources. And then on the other hand, organizing those hundreds or even thousands of patient records to deliver precisely what a provider needs at the right moment in time. So with that said, I think it's the right time to bring up our third and final poll question of the day. Garrett, if you don't mind helping me bring that up. Thank you. Looks like it's
All
up
right.
there.
Yep, you guys should all see that on your screen, and same deal as before. To what extent is your organization currently incorporating external medical records into your risk adjustment strategy? We either do not currently use external data, or we are in the planning exploration phase. We use external data reactively on a case-by-case basis, or we have a systematic, proactive process to ingest and analyze this data.
Very interested to see where we land on some of these questions. So thank you all for your responses. We'll give it another moment.
Yeah, looks like most of the responses have come in. We'll close it down maybe another 10 seconds here.
Sounds good.
And give folks a chance to put in their final selections. All right, I'm going to close it down in 5, 4, 3, 2, and 1, and then I will share the results. All right, Shane, are you able to see the results?
I sure can. Thank you, Garrett. And I can read out some of what we're seeing here as far as what we received from the audience. So leading the charge here with 42% of our audience have a systematic and proactive process to ingest and analyze external data, which is excellent and great to see. 26% are using external data reactively on a case-by-case basis. 21% do not currently use external data, and 11% are more in that planning and exploration phase. So really helpful to understand where the audience sits today as far as these different sort of phases of maybe maturing risk adjustment to include some of those external insights. And so I think from here, Dr. Taylor, I'd love to hear some more from you around your perspective on why it's so important to tap into a variety of data sources that are outside of the native EHR and claims data, right? When we think about national EHR exchanges and pharmacy exchanges and state HIEs, and also just would love to hear more about some of the biggest hurdles in making this data actionable as well.
Yeah, this actually goes somewhere, so hang on. I was reading a book to my grandkid, one of my grandkids, and it was about a little mouse that rode a motorcycle up a telephone cord to get somewhere. I forget the name of it. And my granddaughter said, "Grandpa, what's a telephone cord?" Because they don't exist. So what we used to do, and the way we used to think about things, no longer exist. So back in the day, we would have a patient come in and have no clue who they were, why they were there, what they were doing, and they told us about the little white pill and the thing that you sit in the tube, and that's all we knew. So then we'd have to get old records. We'd send a request. It'd take forever. So right now, it's a huge advantage, not only not having a telephone cord, but having information at your fingertips when the patient arrives, especially in the value-based care model. One of the goals is to decrease downstream spend, and if you have to repeat every test they've just had somewhere else, total waste of time, total waste of money, and so having that information up front is crucial. The external data, if it just comes from claims data, it's not going to be as accurate as what people think. With two different companies, Kaiser being one of them, our own internal data was just wrong because in hospitals they code probables or rule outs. When the patient shows up at the lab, the tech puts in the diagnosis of diabetes. When they see the oncologist would put in breast cancer when really it was history of breast cancer. So I just talked to another vendor just the other day, and he made the claim that wasn't as gracious as mine, that 40% of claims data is incorrect. I've actually audited it, and I found 20 to 30% is incorrect, even after auditing to see if those patients had those conditions. So it's crucial to get more than just claims data and take claims data with a grain of salt. Because you just don't want to hang your hat out and expect the doctor to refresh something that isn't there.
To add to that, agree with everything you said there, and the 20 to 30% has definitely been my experience too. I mean, something was ordered or it's on an old note, and so it gets there. Or, there's also the natural course that some things just resolve over time. That breast cancer and history of breast cancer. What I have found particularly useful about our work with Connective, and we're working on iterations and getting better at this, is we're able to take the claims data, but then we're able to take it to the next level by saying, well, if this diagnosis, we'll say heart failure, is out there for this patient on claims, let's go find what the physician's immediately going to ask. What's their last echo? And, connect those two things together so that this gets back to like the efficiency idea too, of, all right, we want to know if the patient still has this condition. We know physicians are going to go look for X, Y, or Z to help validate it, and also probably to help to guide their decision on how to manage it going forward too. And Connective is very good at going out and searching the whole breadth of data out there, whether it's internal to your EHR or, more importantly, external, and being able to connect those things two together. And really, the approach I like too is iteratively working on really high impact, high yield, high acuity or burden illnesses, the COPDs, the heart failures, the CKDs, the major depressive disorders, and being able to marry up the claims data, but also pull in the objective information and then find a way to get it through to the point of care provider so that they have the right information at the right place for the right patient at the right time. That's really been really, really nice part of this work.
That's very helpful perspectives from both of you. I appreciate you sharing that. And so, for those of our audience who joined and are, not taking advantage of external insights and medical records today, right? There's a lot of, improvement that there's there to be had when it comes to incorporating that level of data, when it comes to the accuracy of the way you capture risk. And even for those who are capturing that data at some level, being able to do so in a way that can translate into something that is actionable for your providers to actually, implement in the care delivery process at the right time is a crucial part of the equation here as well. So really helpful perspectives on that topic in particular. And I think really meaningful as well when we think about the, navigation of a V28 framework and increased rigor of RADV audits as well. So I think with that all said, we'll shift gears here again and just think some more about the future. And I think we've already begun to do so to some extent here, but just thinking about the leaders that we have in our audience on this conversation today, whether they're clinical or operational or financial or administrative, they're all tuned in to better understand how they can better tweak their programs for effectiveness and for sustainability. So as we look ahead, I think this process of managing chronic conditions is going to continue to evolve, and what was once maybe simply measuring accuracy of the problem is going to become a comprehensive measurement of accuracy partnered with making it actionable for providers to actually deliver better care as well. So we're really moving in this direction of more comprehensive chronic condition management. And a lot of this is enabled by technologies similar to Connective Health. So I think a question that I would ask here as we think about the future for both of our panelists, and maybe Dr. Williams, we can start with you, is just what would you advise an organization on how to future-proof their chronic condition management strategy?
I think actually a lot of, what I was just talking about of not just providing the information about the historical claims and what's been known about the patient, but then marrying it up with the clinical data that needs to come with it. I like to think of like the risk adjustment or like burden of illness process as like the necessary but not sufficient part of how you're going to be successful in, value-based arrangements or ultimately in providing patient care. It's not enough to just say the patient has the condition. You also need to manage it effectively. And I think that's a big emphasis of the V28 shift, is it's really taken out a lot of the kind of secondary conditions that don't require necessarily as direct and thoughtful and over time, chronic management. It's really slimmed down the number of HCC conditions to a lot of the, what I would say are most clinically meaningful ones. And so, yes, it's good to name them, but the more important part is managing them. And then, if you're the provider and you want to do this all efficiently, what you need is data to help drive you along that way. And, I think that's really where pulling in effectively, efficiently, and at the right time, right place for the right patient, the data behind it that both supports, yes, they do have this, but also here's the information you need to manage it going forward. I think that's going to be increasingly important for managing utilization and overall quality of care.
Yeah, when you see so United Health is the most recent company struggling with costs of healthcare and their bottom line and all the different variables they look at. One of the difficulties is that many of us are living proof that we can out-eat any exercise program. So similarly, you can outspend any diagnosis capture process you've got out there. So spending a significant portion of time in combing through the charts and trying to get things is, as Scott said, is crucial. But if you don't cut your spending on the back end, you don't cut your eating, it's never gonna you're never gonna turn a profit. So being just as aggressive on managing your costs and managing the costs a lot of times means effectively managing the patient's health care. So the doctors buy into that very quickly. One of the things that we did, and one of the places I worked, is sometimes we skipped the cheapest test and went to the most expensive test just because it was more efficient in the long run. So looking at managing your patients well from a cost containment process while maintaining clinical quality is important, and that's one of the areas that it's really crucial to have physician involvement. So you don't outspend what you collect. The other thing is that the diagnosis capture is not exponential. It flattens out at some point because people don't gain a new HCC every year. I always use my mom as an example. So from 65 to 85, she only had 3 HCCs the whole time. So she had 3 chronic conditions, and one of them got worse. And after a while, that's what did her in, was there were no new HCCs. So one of the things that you need to realize is it flattens out. It doesn't keep going. So once you've got somebody well managed, you don't have to focus on them as much. We set a trigger of they had increased hospital or ED visits, or their cost, their spend went up. That's when we looked in to see, well, do they have a new HCC, or is just this one of the old ones acting up? So you don't have to do full court press on every single patient all the time. Some will stabilize out, and then you can focus on the others who are in the hospital and having multiple ED visits or driving up outpatient costs.
Perfect. Thank you so much for those answers here. And I want to be mindful of time here as we try to allow for some time for questions. But maybe if we could just do a minute for each of you here as we wrap up some of the topics that we've discussed today. And I think you've begun to answer this question a little bit, but if every value-based care leader in our audience could do just one thing differently tomorrow to improve on their program, is there anything else you'd like to add as far as advice? Maybe Dr. Taylor, I can start with you.
I'm the slow thinker, so you should have started with Scott. The one thing, put something into practice to start looking at managing your costs. Because I hate to say that, I wouldn't say that capturing the diagnosis is easy, because there's a lot of things to go through that you have to do. But compared to cutting costs, cutting costs is a lot more difficult. So you almost need to put as much or more time into looking at your spend and decreasing your spend while maintaining quality. That's where I'd tell them to focus.
Gotcha. Thank you.
I think for me, it's lead with the clinical aspect of this whole work. I mean, one quick example, we want to know like the burden of illness, no more, no less. And one, it really allows, it's important at the individual patient level, but it's really important at the population health level when you have these big populations that you're taking care of. You want to go out and do some sort of intervention. Like one thing we've run into at ilumed is we're trying to get our patients who have systolic heart failure on guideline-directed medical therapy, because a lot of them, for whatever reason, are not. Our biggest first step actually has been just like the noise, the claims data, and the process of people having heart failure diagnosed that is not actually truly heart failure. And it's leading to us not having the right patient population, right time. And so, it really gets back to why it's so important to just like keep this very clearly clinically oriented so that you know exactly what your patients have. And then you can lean in on the evidence base on how to like optimally manage. and you can let your cost trends, you can really lean in on those and go to the areas to make sure that you're targeting right intervention to the right population.
Fantastic. Well, thank you both so much. Really appreciate your perspectives here as it relates to the topics, very important ones that we've discussed today. And I think it'd be great to now turn to the audience to see what kind of questions have come our way. So Garrett, if you're with us, would love to hear from you if there's any questions that have come in that we can start with. And as I say that too, I know that on the Connective Health team, our Chief Product and Customer Success Officer is also here to support some more technical questions should they arise as well. So Chris, welcome you to join us if you'd like. But Garrett, I'll turn it to you.
Very good, very good. Yeah, well, we did have a number of audience questions that came in. We have a big audience today. If you have a question, by the way, and you would like to submit it, you can do so using your control module. You've got a space specifically for questions. We're going to get to as many as we can. I doubt we'll be able to get to all of them, but don't worry, someone will make sure to reach out to you via email afterwards. So without further ado, let me go ahead and start with this one. Who is cleaning the external data, and how do you prevent all the claims from being presented?
Perfect. That's an excellent question.
I will say one thing that we have found helpful, and this is really sort of like a work in progress, but working with Connective on trying to match up what's out there objectively in the external data that matches up with the claims or doesn't has been very, very valuable. I think it can succinctly and get objective clinical data in front of a provider to help them be able to make that decision. If the condition's there, it also provides them with the information to often to take the next step and sort of what's the appropriate management. So I think that's been very, very beneficial in the work we've seen.
Yeah, and the answer is no one's cleaning up the external data, so you need help.
Yeah.
And there's a lot of different ways that you can do that. If you're trying to clean up your own, one caveat we had is anytime we had a new diagnosis reported from a single external source, we automatically ignored it because when we would audit it would be wrong. That's why so once again the Connective folks link up existing documentation to a claim, and if it doesn't link up, they discard it as well. So that's really the biggest thing is getting more than claims data, using it to validate your diagnoses that are in the claims data so that you have an accurate picture and you don't waste your time or the physician's time.
Yeah, and I can add some color to that as well from a Connective Health perspective, and it's a conversation we're happy to continue to have as well with whomever may have asked it. But tapping into the breadth and depth of external data is it's a feat in and of itself, and then being able to make that data actionable is definitely a significant process that Connective Health has engaged with. And our technical team and engineering teams do quite a bit of work when it comes to applying deterministic models that help organize that and curate that data into what is most important for providers. Of course, artificial intelligence is something that's emerged in recent years as something that could be an application there when applied in the right way, in a conservative way, in a healthcare setting. And then, of course, just delivering that into the current and existing workflow is something that Connective Health does a really good job of, which goes back to the actionability of that data when it is cleaned as well. So really appreciate the question, and I think it's worth going in greater depth over time as well. Happy to take that back.
Great. Next question is this. We do chart preps for providers. What suggestions do you have to get providers to engage in this process?
So my suggestion would be trust is key, and you're better off, and I'll just say it crassly, you're better off eating income on minutia to gain their trust. So if you've got a heart failure that's out there and you've got a senile purpura, don't act as though they're both equally important, because they're not. And that's why in V28 senile purpura went away. They're basically just the bruising you get on your arms and hands when you're my age. So there are some companies that actually did a senile purpura push to try to increase the diagnoses there, and that's why they're up the creek now that it's no longer in the model. So go keep the main thing, and go after the heart failures and the AFibs and the previous MIs with heart problems and those things. That's going to gain you credibility and get them to sit up and pay more attention. And then the other aspect is err on the side of accuracy, not completeness, as far as collecting diagnoses. So if you've got one that's definite, no doubt, you've got a low ejection fraction, present that one. If you've got one that's a maybe and they're going to have to search through the charts and look at this and look at that, gain their trust first, and then they might be willing to do that later on, but gaining their trust first by diagnoses that are well established is a systematic and progressive approach that has proven to be successful.
I think everything Jim just said there is very much in the keep it grounded in clinical medicine. And that's going to be the path to both the provider's heart and to better outcomes for the patient.
If practice the main plays, not the trick plays, because too many time if you got to do basic blocking and tackling, not do a halfback handoff, quarterback end zone, whatever. So keep the main thing the main thing.
Love the analogy.
Very good. Yeah, very good. Well, unfortunately, we are out of time, guys. We've got again a lot of great audience questions that keep coming in, and if you have a question that hasn't gotten answered, please go ahead and drop it in now, and someone will make sure to reach out to you to get your question answered. But I wanted to thank you, Dr. Williams, Dr. Taylor, for a fantastic presentation today. And obviously, and you, Shane, as well, for moderating. If you'd like to get in touch with them, here is Shane's information here. At least you can reach out to him. But I did want to encourage you all as we close out today to head over to vbcexhibithall.com. Check out the Connective Health virtual exhibit booth. There's a little picture of it here. There's be a link to it in the slides for today, and there you can read up more on them and what they're doing. There's a lot of great resources and kind of educate yourself on them, and of course be able to reach out to them directly. But again, if you would like to reach out to them, feel free to do so to Shane. Again, his contact information is here on the screen, or I'm happy to facilitate an introduction as well if you want to just reach out to me. But I want to thank you all so much for joining us this afternoon. I hope you will join us on the next one. And until then, have a great rest of your week. Bye-bye.
Thanks so much, Garrett. Bye, everyone.
Bye.
Thank you all.